Assalamu alaikum. So good afternoon, everyone, and thanks for the opportunity to present here today. My name is Wissam Ghandoura. I'm an assistant professor at Al Qura University in Mecca and a senior radiation therapist at King Abdulaziz University Hospital. My presentation today will be about some of the work I did in Australia as part of my PhD, looking into estimating the optimal and comparing it to the actual utilization rate of lung saver in the Australian population. So lung cancer, as you know, is a major cause of death worldwide. In Australia, it's actually the fourth most common cancer diagnosis, responsible for almost a fifth of all cancer deaths. In terms of the 5-year survival rate, it's only about 17%, which is pretty low compared to other types of cancer, as you can see here. Stereotactic ablative body radiotherapy, or SABR, is currently the standard of care for inoperable early-stage lung cancer. For operable patients, surgery is still considered the standard of care, although there's a big debate about this, and it's been really hard to settle this debate, mainly because of how difficult it is to conduct randomized control trials in this setting. However, the advantage of SABR compared to surgery, obviously it's non-invasive and much more tolerable, allowing patients who are elderly or those with poor performance status or comorbidity to have this curative treatment option rather than being referred to palliative therapy or sometimes even left untreated. We know from the literature that since the introduction of lung saver, the number of patients who are receiving curative treatments have significantly increased, while the number of patients left untreated has decreased, leading to ultimately improving the overall population survival. So estimating the optimal utilization rates is basically figuring out the total demand that we need for a particular treatment within our population. The idea is once we have this demand, we can use it as a benchmark against which we can compare the actual utilization rate within our clinical practice to figure out if there's any gaps in the provision of radiotherapy treatment, and hopefully to further improve the process of decision-making, resource allocation, and basically plan for a more efficient provision of radiotherapy treatments. Unfortunately, from the literature, we know that radiotherapy in general is very underutilized. And we also know that this underutilization has a negative impact on patient survival, leading to years of potential life being lost for cancer patients. So how do we estimate the total demand for lung saver? There's more than one way. We use what is known as the evidence-based approach. And this basically has two main steps. In the first step, we identify all the indications or the clinical scenarios where lung saver would be recommended. And this is based on the best available evidence and clinical guidelines. And we use this information to construct a decision tree or a model for optimal utilization. The next step is to look at the epidemiological data in our population to figure out the estimates of these indications within our population. And the final step is to add all these numbers to figure out the total demand or the optimal utilization rate for a particular treatment. For this case, we are using for lung saver. So this is just a list of all the clinical guidelines that we reviewed, a total of 15 different guidelines, including NC's, ESTRO, ASTRO, NICE, and so on. And we also focused on more Australian-based guidelines. We summarized all these indications in this table, showing all the different indications for lung saver, the guidelines that recommended the treatment for each indication. Of course, the guidelines didn't always agree with each other, so we rated the level of agreement between the different guidelines. And we also evaluated the quality of the evidence used to recommend lung saver for the different indications. So after taking into account all these guidelines, this is our decision tree or our model. It has all the different indications, including stage, performance status, operability, and so on. And at the end here, as you see, it can tell if SABR would be recommended for this indication or not. We then looked at the epidemiological data. Obviously, we focused more on Australian-based data. But the beauty of this model is that if we wanted to apply it to a different population, say, for example, here in Saudi Arabia, the model could be easily modified and updated to be applied to the Saudi population or to any other population, provided that we have the data that we need for the model. Now, the one thing that's missing from our model is the distribution of peripheral, central, and ultracentral tumors for lung SABR. Of course, this is important to know for the treatment of lung SABR. And as far as we know, there's currently no published data regarding the distribution of central, peripheral, ultracentral. So another part of my PhD was developing and validating an automatic segmentation tool for automatically segmenting the proximal bronchial tree and then measuring the distance to the tumor, which is how we usually define tumor centrality. This tool is fully automatic, so we can apply it on as many data sets as we have, like we use in data mining, for example. And we'll be able to contour the proximal bronchial tree on all these CT scans, measure the distance to the tumor, and then tell us the distribution of tumor centralities for these patients. I wish I had more time to talk about this tool. For now, I'll just refer you to this paper that we published a couple of years ago. So we applied this tool on a data set of 430 patients treated at Liverpool Hospital. And fortunately, many of these many of these patients, were missing the DICOM images. So we could only apply the tool on a total of 234. We wanted to apply it on more patients, but unfortunately, with the COVID restrictions and the time limits on my PhD, we had to accept this as a limitation in the study. So these histograms basically show the distribution of the distance between the tumor and the proximal bronchial tree. We broke it down here by stage. So with this information, we're finally able to complete our model. All we have to do now is combine all these numbers to give us the final optimal utilization rates for different indications. So these green numbers here are the calculated optimal rates of utilization for different scenarios. So for all lung cancer patients, about 6% of them should be receiving lung SABR. For stage 1 alone, about 32% should be receiving lung SABR. And if we only look at inoperable stage 1 with good performance status, about 82% of them should be receiving lung SABR. We also did some sensitivity analysis using the tornado graphs. This is basically to figure out the effect of different variations in our data and how they affect the calculated utilization rates. The biggest variation was due to the proportion of patients who are considered operable or inoperable. But in the Monte Carlo simulations, all these variations led to a variation of between 4 and 6% in the total demand for lung SABR. We also looked at the actual utilization rates within our clinical center. So from the total of 430 patients, only about 15% had lung SABR, while 58% had radical, and 27.4% had palliative treatment. We did some time trend analysis, and you can see the general trend is an increase in the utilization of curative treatment, increased trend in SABR and radical, but higher in radical treatment. But we're still not meeting the demand for the lung SABR treatment. Last thing we did is we also looked at practice pattern studies from different countries, including Australia. And as you can see, there's quite a bit of variations in terms of actual utilization of lung SABR. So for early stage, there's a variation between 6% up to 20%. And if we only look at the inoperable patients, there's also a variation between 14% and 55%. But overall, the main message is that we are not even close to meeting the total demand or the optimal utilization rate for lung SABR. We also published this paper recently, which I'm very happy about. So just to summarize, we used an evidence-based approach to calculate the total demand for lung SABR in the Australian population. And we also used it to compare it to the actual rates of utilization in Australia and also in other developed countries. And we basically found that LungSaber, this curative treatment, is being underutilized. For future directions, I'm hoping to use this model to apply it in the Saudi population, or if anyone else is interested, I would be happy to have a chat about what we can do about collaboration. There's also other things we can do in the model in terms of quantifying the benefits to the patient's survival if we say that we are able to meet the optimal utilization rates. Thank you.